Hello guys, welcome back to Clinically Clear. So today we'll be looking at the syndromic management of urethral discharge and vaginal discharge in sexually transmitted disorders. So first of all, urethral discharge. Due to urethritis, the causative organisms could be Neisseria gonorrhoeae, gonococcal urethritis, chlamydia trachomatis, trichomonas vaginalis. All these are non-gonococcal urethritis. So what you will do first? First, you will take the discharge. You will do lab diagnosis. Gram staining, you'll see for gram-negative diplococci. If you see gram-negative diplococci, kidney-shaped gram-negative diplococci, it is Neisseria gonorrhoeae. Neisseria gonorrhoeae. If you don't see any gram-negative diplococci, but you still see 4 to 5 neutrophils per oil immersion field, it is non-gonococcal urethritis. So from this, we'll get to know the lab diagnosis. So we've diagnosed the condition. We next go for treatment. For chlamydial as well as gonorrheal urethritis, that we'll go for 400 mg cefixime oral single dose and azithromycin 1 gram oral single dose. And if the patient is allergic to azithromycin, then we'll go for erythromycin 500 mg 4 times a day for 7 days. This is the standard treatment for any gonorrheal infection or chlamydial infection. Cefixime 400 mg single dose, azithromycin 1 gram single dose. If patient is allergic to azithromycin, erythromycin 500 mg QD for 7 days. For trichomonas vaginalis, secnidazole 2 gram single dose. So now we have treated the patient. We have to also give health education and counseling about sexual abstinence during the course of the treatment, safe sex practices, provide condoms to the patient so that after the patient recovers, it does not contract another STD. Advise voluntary testing for other sexually transmitted disorders like HIV, syphilis, hepatitis B. Tell the patient, go get tested for other sexual transmitted disorders. I'd schedule a follow-up after 7 days for looking at these reports. Schedule a follow-up after 7 days. And very important, never ever forget, we have to examine and treat all the recent sexual partners as well, because even they might have contracted it, right? So it is important to examine and treat the sexual partners. So if they also have gonorrhea or chlamydia, you will again give 400 mg cefixime oral single dose, 1 gram azithromycin oral single dose, or erythromycin 500 mg QD for 7 days. So after you treat the sexual partners as well, patient comes for follow-up after 7 days. You check the reports of hepatitis B, syphilis and HIV. Some cases there can be persistent discharge. Persistent discharge usually because of reinfection or because of bad treatment compliance. Patient is not taking the medication. Patient is not following safe sexual practices. So there has been reinfection. Persistent discharge has come. So then what you'll do, you'll again assess the treatment protocol. What to do next? You'll assess the condition and then you'll refer to a higher center if required. This is about urethral discharge. So urethral discharge, you'll first causative organisms, lab diagnosis, what you'll see, gonococcal urethritis, non-gonococcal urethritis, treatment plan for trichomonas vaginalis, treatment plan for gonorrhea and chlamydia, health education regarding sexual abstinence, condoms, then follow-up, voluntary testing for HIV, syphilis and hepatitis B, examine and treat all the recent sexual partners, follow-up. Persistent discharge could be due to bad treatment compliance or reinfection. Assess the treatment protocol, refer to a higher center if needed. Then coming to vaginal discharge. Vaginal discharge, the causative organism, if it is vaginitis, if the vaginal discharge is due to vaginitis, it can be trichomonas vaginalis, it can be vaginal candidiasis, that is Candida albicans. If the vaginal discharge is due to cervicitis, it can be Neisseria gonorrhoeae, gonorrheal cervicitis, chlamydial cervicitis. So these 4 are the most common main causative organisms for an STD leading to vaginal discharge. First, you look at the history. You will have consistent findings like genital itching, burning micturition, increased frequency of micturition, swelling or ulcer over the vulva and the vagina. You can have a swelling or an ulceration over the vulva and the vagina. All this will be in history. Examination, depending on the discharge. Greenish discharge usually associated with trichomonas. Curdy white discharge associated with Candida albicans. If you see cervical tears, cervical erosions, cervical ulceration, cervical tear, cervical erosions, then it is probably due to cervicitis, that is gonorrhea or chlamydial cervicitis. To confirm, you will go for lab diagnosis. Lab diagnosis, if you want to confirm trichomonas, which is a parasite, which is a Yeah, it's a parasite. You'll do wet mount microscopy to see the trophozoite, Trichomonas vaginalis. Candida, you will go for KOH preparation to see the fungal colonies, so Candida albicans. Cervicitis, gonorrhea, you will go for gram staining. You will see the gram negative kidney shaped diplococci, that is gonorrhea. Again, now you'll go for the treatment. Same treatment for chlamydia and gonorrhea cervicitis. That is cefixime oral 400 mg single dose, azithromycin 1 gram oral single dose. If allergic to azithromycin, go for erythromycin QD 500 mg for 7 days. For trichomonas vaginalis, again the same treatment. Secnidazole 2 grams single dose. For candidiasis, fluconazole 150 mg single dose. But if the woman is pregnant, then because sexually transmitted disease, STIs are common in pregnant women as well. First trimester, instead of giving oral secnidazole, instead of giving oral fluconazole, we'll give pessaries. Pessaries are placed in the vagina and the cervix, which and they act as a local drug. So basically, the drug has local action. So metronidazole pessaries, clotrimazole pessaries. So these are given in the first trimester. Why? Because the secnidazole, fluconazole, they can cause excessive vomiting. They might have any teratogenic effects. So that is why we prefer locally acting drugs. Second and third trimester, we can give secnidazole, but half an hour before the secnidazole, we give 10 milligram metoclopramide. Metoclopramide so that acts as an antiemetic. Already patient might have hyperemesis gravidarum where pregnant female feels like vomiting again and again. So we'll give metoclopramide half an hour before secnidazole so that the patient does not vomit. Again, go for health education and counseling. Same thing. Sexual abstinence during the course of treatment, provide condoms, safe sexual practices, schedule follow up after 7 days, advice for voluntary testing of HIV, hepatitis B, and syphilis. Get them for follow up 7 days later. Persistent discharge, it could be due to bad treatment compliance, it could be due to reinfection. Again, assess the treatment protocol and refer to a higher center if needed. So it is very similar, just the causative organisms differ, and here in the vaginal discharge is a little bit more detailed with history and lab diagnosis for all three of them. That is it for syndromic management of discharge when it comes to sexually transmitted diseases. Thank you for watching.